Yeah, the first bill in that we're taking up is the what's popularly known as the insulin bill, House File 3100 by Representative Howard. And if we could have a motion, Representative
Mr. Chair?
Olson.
I think Representative
Oh,
Leahy-
Representative Leland,
Yeah.
that's right, it came out of Health and Human
Yes,
Services.
yes, it
Yeah.
certainly did. Thank you, Mr. Chair. So I move that House File 3100, the third engrossment, be recommended to be placed on the general register.
Okay, the motion is before us. Any discussion? Seen?
Mr. Chair,
Oh, that's right, we don't need to vote yet, yeah. I was confused that we're not adopting a division report, but the bill is before us. Okay, takes a new session, a little time to get used to it. We do have an amendment, however, that Representative Nelson is going to move. Representative Nelson.
Mr. Chair, I'll move the 3100A 13-1 amendment. And my understanding of this amendment is to put it in line with the fiscal note that we have, that they got yesterday.
Okay, so any discussion on that motion? Seeing none, then all those in favor signify by saying aye.
Aye.
Opposed, motion carried. Representative Howard on the bill as amended.
Mr. Chair, thank you, and thank you, members. This is the Alex Smith Insulin Affordability Act, and many members here have had a chance to hear this bill as it's moved through the process last year and then this year as well. At its heart, this bill is about creating a safety net so that no Minnesotan loses their life because they can't afford the insulin they need to survive. We have all heard the story of Alex Smith from Nicole and James, and it's heartbreaking that someone could lose their life simply because they didn't have enough money in their bank account that day to fill their insulin prescription. And since last session, 2 more Minnesotans have lost their life. That's why we are here today, and I'm grateful for the committee to hear this bill to move forward with the urgency this situation, this crisis deserves. In broad strokes, this bill would create a path so that eligible Minnesotans, and those are folks most at risk of rationing their insulin, would be able to get an emergency fill of insulin at the pharmacy when they need it. In addition, we would connect Minnesotans to long-term resources through a navigator to make sure that if there are existing public programs, we can secure those, get them onto those programs, and also connect them to what other affordable care options might be available to them. We are utilizing a third-party administrator to process the claims in the pharmacy level. That allows us to use the existing infrastructure in place pharmacies utilize so that we can set a program up quickly and get insulin into the hands of patients when they need it. This bill is funded through a combination of public funds and a fee on insulin manufacturers. There's about $1 million in public costs that are largely to set the program up through the Department of Administration and then through MNsure. And we will have a fee on insulin manufacturers. There are just 3 manufacturers that control virtually the entire global supply of insulin that would be assessed this fee based on a proportion of their share of the market. And the largest driver of that cost in this fiscal note is simply the cost of insulin. And happy to answer any more specific questions. Mr. Chair, I'd stand for any.
Okay, any questions? Representative Scott.
Thank you, Mr. Chair. And Representative Howard, when you were in the Judiciary Committee, we talked about some data provisions, audit trails, and some other issues that I thought should probably be in this bill. And so were you planning on adding those in on the floor, because I don't see them in the present bill?
Representative Howard.
Mr. Chair, Representative Scott, we did add the amendments that you offered in Judiciary, and thank you for those good consumer protection amendments. I've had some conversations with this specific data set issue and don't have those specific data sets included in the bill, but happy to continue the conversation before we're on the floor, if that's what you're asking about.
Thank you, Mr. Chair. And Representative Howard, could you point to me in this iteration of the bill that we have before us where those data provisions are regarding the audit trails and the role-based access, please?
Representative Howard.
Mr. Chair, I'm just glancing through here. I believe the amendment is included in a couple different places. On 9-15, we have information about data. There was a specific amendment also to the third-party contractor piece that's included.
Because I don't, Mr. Chair,
Representative Scott.
thank you. I don't see the audit trail language in the section on 9.15 and following. So evidently, it must be somewhere else, because I don't, I don't see it here.
Mr. Chair,
Did
Representative
you get
Scott, are you,
some, from Mr. Chung, did you get some information, or he could come up to the table if necessary?
Mr. Chair, Representative Scott, the amendment that we passed in judiciary, as I understand, is incorporated. That's the extent of what's incorporated here. If there's an additional piece, I'd like to follow up offline and make sure that we have a conversation.
Mr. Chair?
Well,
Representative
if
Scott,
somebody else on the committee has an answer.
Representative Leaving.
Well, thank you, Mr. Chair. I just wanted to kind of along with what Representative Howard is saying, in the Health and Human Services Finance Division, which was the last stop, we did adopt an amendment. This was, as you know, as members know, this has been one of those bills that's gone to various committees in various forms with clone bills, and we did pass a really good amendment in judiciary, and we adopted that same amendment, I understood that it was, in our bill. So if it isn't in here, it would be a mistake, but I think it is. This has been engrossed, so it should be in here. And from there, I think Mr. Chun probably would be the best one to answer where the specific pieces of it are.
And he's just come forward, so. Mr. Chung, maybe it'd be more efficient if you don't mind, did you hear I assume you heard the question because you were providing counsel.
Mr. Chair and members, I think the question was whether the language that was put in civil law is in this on data privacy. That amendment was put on, as Representative Leaving said, in the HHS Finance Committee. I'm not sure if I can find every single piece, but for example, if you go to page 2, line 2.6, that's some of the language from the amendment. Another piece from the amendment would be on page 9, lines 10 through 14. And then there's also some data language beginning on page 9, line 15 through about line 23. So the amendment was engrossed into the bill. Okay, yeah.
Hey, Representative Scott.
Thank you, Mr. Chair, and I'll continue to look through the bill here, but I'm still not seeing the audit trail language, but I'll keep looking.
Okay. Can anybody, well, right now get any guidance on that, or we'll just leave it to Representative Scott to keep looking? Okay, any other discussion? Representative Albright.
Okay.
Thank you, Mr. Chair. Representative Howard, you have two partitions in the bill. One is for an emergency supply, and as I understand it, and please correct me if I'm wrong, what is the max out-of-pocket cost to a participant in the emergency insulin side of your bill?
Mr. Chair, Representative Albright, how the eligibility is structured in this bill is that, in broad strokes, what we're trying to capture is are folks that are, they have income that puts them outside of being accessible for most public assistance programs where they would have access to affordable insulin, but they're not making so much money that they can afford those large out-of-pocket costs if they're either uninsured, on a high-deductible health plan, or in some cases on Medicare. The eligibility is structured, if your copay is $50 or less for insulin, you're not eligible, because the presumption is then you do have access to affordable insulin. If you are in those income ranges and your copay is $50 or greater, you could be eligible for the emergency insulin program at 500% of federal poverty guidelines. And the long-term insulin piece, we set that a little lower at 400% of federal poverty guidelines. And that's a product of working and trying to align and get bipartisan agreement with the Senate, which is where they were at in our latest discussions.
Mr. Chair, Representative Howard, I understand the parameters for how the determination goes to the copay, but somewhere along the line, and I think I've heard this bill 4 or 5 times now, I haven't gotten a clear answer in terms of if you need insulin on an emergency basis, what is my out-of-pocket cost to get a 3-month or a 1-month supply of insulin?
Mr. Chair, Representative Albright, the cost would be a $30 copay for a 30-day supply of insulin. So and you're also available to access a 90-day supply of insulin. That would be $90 for that supply of insulin. So it's structured as a copay. And again, that's an area where, you know, if I had it my way, I wouldn't have any copay. But in the interest of trying to come to consensus with the Senate is where we have a copay at $30.
Mr. Chair, thank you. Representative Howard, what is the out-of-pocket cost for the long-term program?
Mr. Chair, Representative Albright, if you qualify for the long-term program, you are receiving a monthly supply of insulin at no cost for up to a year. So how that could play out is you get your emergency refill, and then you're connected with the navigator through MNsure who can help assess your long-term options. And let's say through that process, you learn that come open enrollment, I could qualify for a plan on the MNsure exchange that would cap my copays at $0 or $25. You'd be able to get a supply of insulin. Let's say you applied in June. You'd be able to get that supply up until the next enrollment period when you can get enrolled and have affordable coverage on the exchange.
Mr. Chair, thank you. So can you walk me through the practical process that a diabetic would need to follow to receive an emergency supply of insulin? And I would appreciate understanding if there are changes to where they might have to go in order to realize an emergency supply in the environment that you described.
Mr. Chair, Representative Albright, that's a really good question and one that's sort of been at the heart of how we're structuring this bill. What we want to do is make a program that's as barrier-free as possible for the patient that allows them to access their medication how they would normally. So how this is structured that if you are a patient and you cannot afford your next supply of insulin, you have a high deductible health plan, your out-of-pocket costs are going to be $300, $400. You're able to apply online on the MNsure website. There'll be a basic application that'll ask a series of questions to based on your eligibility and income levels, attesting that you're facing an emergency, and instantaneously you will get a receipt essentially from MNsure. That's in one hand, and with that and a valid prescription, you hand that to your pharmacist, and it can be your community pharmacist where you have your insulin on file. To take those 2 bits of information, and there you can get your emergency supply of insulin. And I just want specifically, there's the importance of this is to allow patients to access their insulin where they would normally go. We shouldn't be forcing patients to have to go to an emergency room, et cetera. That's part of this bill, is to create that network so that Minnesotans can go where they normally go, the community pharmacy, to access their medication.
Mr. Chair.
Representative
Thank you, Mr. Chair. You iterated 2 pieces of paper that someone needing to realize an emergency supply. One is this documentation from the website that's going to be run by MNsure. And the other one is a valid prescription. a valid prescription? What if they don't have a valid prescription and they just broke the last vial of insulin and it's Friday night?
Mr. Chair, Representative Albright, that's another very good question. The legislature actually this last session, one of the things we did pass was Representative Bonner's bill that if you have an out-of-date prescription for a life necessary medication, you can get that refilled. So because of that legislation, you could get a refill. Now, if our bill is really considered with that cost barrier, if you can't access your medication because of cost, this program exists to make sure that, you know, if you're in a situation like Alec, where he had a $1,300 cost for his insulin, and he had $1,000 in his bank account. That's what this bill is aiming to alleviate. But because of the bipartisan work this last session, you should be able to get a refill in your pharmacy if you have an out-of-date prescription and in that situation, the broken vial.
Mr. Chair, if you'll indulge me, thank you. We are relying upon MNsure, and the fiscal note substantiates that all the participants to this program, they assume will utilize the services of MNsure electronically. What if MNsure isn't running, as evidence to MNsure's past? Who will be liable if they can't realize that piece of paper and they die?
Mr. Chair, Representative Albright, one thing I would clarify is I don't want to conflate that we're requiring that MNsure build an insurance exchange, et cetera. It's really a basic form, an application, series of 6 questions or so that folks can file. And the other piece that the bill includes is an ability for a pharmacist to assist a patient with a paper application, et cetera, to make sure that that situation doesn't happen.
Thank you, Mr. Chair.
Representative Graffel.
Thank you, Mr. Chairman. Representative Howard, we received a quite extensive fiscal note on this about 24 hours ago. I'm wondering if you could highlight a couple of the points in terms of cost and relevant assumptions that members of the committee may not be familiar with.
Representative Howard.
Mr. Chair, Representative Garofalo, the piece that I would point to of note, you know, the amount that will be assessed on the insulin manufacturers in fiscal year 2021 would be $38 million. And a couple things about that figure. One, it requires that a series of assumptions be made about utilization for this program. And it is a new program. We don't know how much it's going to be utilized. The assumption in this fiscal note estimates that 70% of folks that are eligible for the program will utilize it. And clearly there has to be some sort of estimate. I'll just call out that when this bill passed the House last session, that was assumed at 25%. And so I submit that I believe that number is significantly higher than will be the utilization rate. However, what we've done in this bill is include language that would basically have a settle up. So in that first year, if the fee did collect too much money, we would give that money back to the drug companies. And the other thing I'd highlight about that number is the lion's share of that $38 million is simply the cost of the insulin. And that number is not the true cost to the manufacturers, because how this is structured is, you know, an insulin manufacturer may produce their vial of insulin for $7, which some studies indicate that's the cost. They will sell it at the wholesale rate for several $100s. And what this bill is basically asking is that they buy back the insulin that they paid for. So the true cost to the manufacturer is significantly less than that number. Are those some of the high-level numbers that are helpful?
Well, Mr. Chairman and Representative Howard, the biennial cost of $76 million is certainly, I mean, even by DFL standards, that's a lot of money. Do you have any comments on that? The 76 million, we have data from the Department of Health that says that we have approximately 2,800 people in the state of Minnesota who suffer from diabetes and don't have insurance. And we're talking about, and the population you're seeking to assist is substantially larger than that, but, I mean, $76 million a biennium? I mean, isn't that kind of a lot, isn't that kind of a lot?
Mr. Chair, Representative Garofalo, one thing I would highlight for members is, again, this is a fee that would be assessed on manufacturers, not a cost borne by taxpayers. We don't believe that Minnesota taxpayers should bear the responsibility of addressing the crisis created in large part by the high cost of insulin. And in some ways, what that number reflects is why we're all here. The price of insulin is completely unaffordable for too many Minnesotans. So to me, that's what the number reflects. It's the cost of the insulin, and as I mentioned, it won't be the true cost borne by the insulin manufacturers.
Well, Mr. Chairman and Representative Howard, I don't know where the insulin manufacturers are supposed to get the money from. They don't have like a pharmaceutical ferry. They just get the money from that disposed money on them. That comes from people who are buying medicines. Now, this is the same shift that we're seeing from the rebate side of things, where customers are paying extraordinary rates, and the insulin manufacturers aren't getting the money. We have the data on that. It's going into rebates, and it's being used to insurance companies and those in the supply chain are gobbling up that money. But I do want to stay focused on the fiscal note. So first of all, on the fiscal note, page 15, the fourth paragraph down, it mentions the 70%. So the number that they list here, the number of eligible individuals for this program, is it correct in saying that, so the 16,600 individuals, is that a number that you agree with, or do you dispute that number that's contained in this fiscal note?
Mr. Chair, Representative Garofalo, to come up with this number, you have to estimate. I would contend that that number is high for utilization, what utilization will be. A couple reasons. This is, the first year we operate this program, we are going to have a lift to make sure that Minnesotans know that it's available to them. And we do include some resources for public relations and otherwise. And, for a set of reasons, that number seems high to me. But again, that's why we included the settle-up language. So in some ways, the fee is going to collect what it's going to collect, and the impact's going to be who utilizes the program. And because we have that settle-up language where we'll, if the fee does over-collect, we'll pay that money back to manufacturers. And I'll mention this is kind of a first-year problem. Once we've ran the program after year one, we'll have a better sense of what those costs will be.
Mr. Chairman and Representative Howard, I want to be clear. When you say the number is high, are you referring to the 70% number, the 16,600 number, or both?
Mr. Chair, Representative Garofalo, the 70% number.
Okay, so, Mr. Chairman, Representative Howard, the 16,600 individuals, do you have an opinion on that number?
Mr. Chair, Representative Garofalo, you may be referring to the 23,000. The 23,700 number are those eligible, and we get to the 16,600 by the 70% figure. But in terms of those that are eligible, to highlight those populations, it's really the uninsured, folks that are on high deductible health plans that have high out-of-pocket costs, and folks on Medicare that have high out-of-pocket costs. And, again, this fiscal note estimates what those populations will be, and we have a mechanism in place with the fee to collect what we actually need.
Mr. Chairman, Representative Howard, I just want to know if you think it's an accurate number.
Mr. Chair, Representative Garofalo, I don't have as much of an issue with that number as the 70% number.
Mr. Chairman, I just want to know if you think it's accurate or not, Representative Howard. So.
Mr. Chair, Representative, I'm not trying to play coy. It's just an estimate. I think it's a fair estimate, but we won't know until the program actually exists and we see how many people utilize the program. And we've structured it in a way that, the fee will collect what it'll collect based on how many people actually use the program. So in some ways, the estimates, based on how we've crafted the bill, aren't as important as making sure that we get it right at the back end.
Mr. Chairman, thank you. And Representative Howard, so at this point, I'd like to go to Section 1, Subdivision 3 of the bill. This is on page 2. This is the subdivision heading of eligibility requirements. And first of all, I want to, and again, I'm referencing the fiscal note as well as the bill. You're in Minnesota Care Medical Assistance. This doesn't apply to you, correct?
Mr. Chair, Mr. Gruffalo, yes.
Yeah, and Mr. Chairman, Representative Howard, can you just explain why?
Mr. Chair, Representative Gruffalo, if you're accessing care in either of those programs, you have access, you are getting affordable insulin either at no cost or very low cost.
And Mr. Chairman, you also in here specifically exclude those who are eligible under the Indian Health Services. Is that correct? And same question, why is that?
Mr. Chair, Mr. Gruffalo, same answer, yes.
Okay. And Mr. Chairman and Representative Howard, we also see that you have a 500% federal poverty guideline in here. Right now, is it correct or not that the 400% federal poverty level, all three major manufacturers have emergency assistance programs? Is that correct?
Mr. Chair, Mr. Gruffalo, that's not correct. The three insulin manufacturers have some level of support for Minnesotans at that 400% level, but a true emergency program that somebody is an emergency, they walk into their pharmacy, they need a supply of insulin. Not all three manufacturers have that. I believe one, as of January 1st, introduced a program like that, and we've heard of a myriad of issues in the implementation of the patient assistance programs. In addition, there are segments of the population that are not able to participate in various insulin manufacturer programs, in particular in the emergency side.
Mr. Chairman and Representative Howard, with the development of this program, are you intending to replace the patient assistance programs that are currently provided by insulin manufacturers, or are you looking to supplement them?
Mr. Chair, Representative Gruffalo, we're looking to create a guaranteed safety net for Minnesotans. The patient assistance programs do not offer that right now. We're not saying they shouldn't exist, and we are glad that there's been some changes to them, but everything we've heard from patients are that they've got a long way to go. So with this, and I will mention that all three have different eligibility standards. They do different things different ways. This creates a uniform, accessible way for Minnesotans in need to access an emergency supply of insulin.
Mr. Chairman, Representative Howard, supplement or replace?
Mr. Chairperson Gruffalo, I thought that was clear from my answer, but supplement, I guess, if you want to. But the issue is what the current status quo isn't doing it. So we need a Minnesota insulin program to guarantee that Minnesotans do have access.
So, Mr. Chairman, Representative Howard, if your answer is supplement, then why are you overlapping with the existing programs? Why not just say if you're not, here's your population, if they're not covered by it, then have the program assist in it? If it's meant to supplement it, why overlap it?
Mr. Chairperson Gruffalo, that is a good question. One of the challenges with the patient assistance programs are frankly their credibility with patients are so low based on their past performance. And they may on paper or on their press release list certain eligibility pieces and things are maybe moving in the right direction, but the patient experience, what we've heard, hasn't improved. So what we're trying to do is create a standard and create a system that we know will work for Minnesotans. And if those patient assistance programs continue to improve and continue to expand and get better, you know, this bill could go away, right? For example, the fee on manufacturers. If the patient assistance programs of the drug-free manufacturers worked well, patients knew about them, they could utilize them, they can go to those programs and this fee won't collect any money. But that doesn't exist right now, which is why we need an emergency insulin program here in Minnesota.
Mr. Chairman, Representative Howard, I would say that if people lack confidence or credibility in healthcare service delivery, I'm not sure trusting MNsure is really the way to go with it, based off of previous track record. Also, staying on subdivision 3 under eligibility requirements, I'm not going to read the whole thing, but there is a word here that is, I'll just To be eligible for the program, an individual must have a valid prescription. They must, for insulin. And then it says attest. They just have to attest to being a resident of Minnesota. They have to attest to not being enrolled in medical assistance in Minnesota Care and these other criteria. And so my question for you is, in the fiscal note we see, we've heard you talk about the out-of-pocket costs for insulin as high as $1,300 a month. If that's the case, aren't we making Minnesota just a huge welfare magnet for free insulin from other states? Why wouldn't everybody come here and get this? Because you're not requiring, all you're requiring is a prescription. If you live in Hudson, Wisconsin, why wouldn't you come over to Minnesota and get your free insulin? If you lived in Fargo, why wouldn't you come to Minnesota? If you lived in Chicago, why wouldn't you make a weekend out of it? We're talking about dosages of $13.50 a month. I mean, aren't you concerned about once again, Minnesota's overly generous public health programs being abused by non-state residents?
Mr. Chair, Representative Garofalo, we have talked, well, one, we need to make sure that we have a program that's tailored for Minnesotans, and that's what this program does. But just a couple comments specific to your question. One thing, by utilizing a third-party administrator to administer this program, we're able to prevent somebody from being able to, say, go into the CVS, get their emergency refill, and then go to a different pharmacy across the street and get another fill. And so calling out this bill is for the emergency supply, you're eligible for a one-time fill in a calendar year. Two, in talking with pharmacists, it would create quite the challenge to, most people are going to go to the pharmacy where their prescription is on file. That is going to be where the lion's share, barring something out of the ordinary, where people will access their medication. So, most people in Chicago aren't going to have their valid prescription on file, at a Minnesota pharmacy. And so we've tailored this program in a way to meet the needs of Minnesotans when they need it.
So, Mr. Chairman, Representative Howard, so with regards to having a prescription on file, that's a 2-minute phone call to your doctor. That's not really an issue. I mean, would you be willing to at least modify that language that the prescription had been written in Minnesota? Or that some level of residency required verification? Because right now, the only thing we're verifying is that there's a valid prescription. But I mean, it doesn't take a rocket scientist to figure out that we've got, take example of cigarette taxes right now. There's a very lucrative bootlegging operation for cigarettes in North Dakota right now, thanks to our excessively high cigarette taxes up here. Do you have any concerns about that being abused? That again, if all you're requiring is, hey, I promise I'm not any of these things, and here's my insulin prescription, are you concerned about other state residents misusing our program?
Mr. Chair, Representative Garofalo, generally I would say the concept of abuse when we're talking about insulin for type 1 diabetics, I just want to call out that, this is a medication that people need to live. This isn't something where, and it's not because you can get it one time, it's not structured in some way where somebody with a valid prescription could come in and get this huge stockpile of insulin. And our priority is to make sure that if you're in that just desperate situation like Alec was, that you have a path to get an affordable supply of insulin.
So, Mr. Chairman, so I think that's my final question. I do think the author and I view this bill differently, but if he's looking to have a program signed into law, I would strongly encourage you to look at that word attest and to come up with something besides just having a valid insulin prescription, especially when you factor in the overall umbrella issues of high deductible plans. That is a significant financial incentive for non-Minnesota residents to come here and use that program. And I would caution you to be aware of that. Mr. Chairman and members, this is, obviously it's a complicated issue. We've had a lot of things change in the last year on this issue. The advocates for this were successful in getting the IRS to change the tax ruling around this as a preventative medicine. It's an incredible accomplishment. Here in the state of Minnesota, Senator Benson, who just did an amazing thing last year by slipping a provision into the omnibus bill. I'm not a fan of omnibus bills, but in this case, it worked out. where she made sure that those insulin rebates that were paid for by insulin manufacturers, that those are now for Minnesota regulated plans 100% going to the patients. The insurance companies can't use that to lower premiums or spend it on other money. And then third and finally is the large and robust expansion of these patient assistance programs, both for emergency insulin as well as for discounted insulin that have taken place. The advocates around this have gotten the IRS to take action, they have gotten Minnesota law changed, and they have been successful in getting the pharmaceutical industry to move. That's a pretty significant accomplishment. Any one of those three. The fact that all three have happened is pretty incredible. But I would just submit to members to be aware as we work on this issue and we touch it, there are unintended consequences with the best of intentions. I've highlighted the attest language and the creation of an entitlement. Just also be aware that there's pharmacists involved in this and what we're asking of them to do and the reimbursement procedures and what they're required to keep on stock. We'll see what happens with the Senate. We'll see where you guys take this. But I do think that this is a serious issue and it merits more serious consideration. I am voting no on this bill today. Voting no does not mean that I'm in favor of people dying, as has been alleged by others. It does not mean that I'm somehow a shill for the insulin manufacturers. I'm proud of the fact that I voted for the opioid bill last year that was opposed by the pharmaceutical industry. But in this case only, the pharmaceutical industry is getting a bad rap. They're not getting the money. This is the rebates are being paid for by the pharmaceutical industry. They're not getting the money. The supply chain, and this is healthcare is such a screwed up issue, everything from top to bottom. We're picking out one single issue on it, but be aware of the fact that in this case, the people making the insulin are not the problem. That's not where the money is going. And we have exhaustive amounts of data on that. People can dispute whether it's 50 or 70%, but a significant portion of the money that's being paid by insulin customers is not going to the insulin manufacturers, and I don't think it's right to punish them when they're not the ones getting the money. So I'll be voting no. Thank you, Mr. Chairman.
Representative Albright. Okay, Representative Long.
Thank you, Mr. Chair. Just a quick question for Representative Howard. Is there anything that would stop a pharmaceutical manufacturer from terminating their patient assistance programs tomorrow?
Mr. Chair, Representative Long, each of the programs actually expressly call out that they could cancel or revoke those programs at any time.
Representative Lieberling.
Thank you, Mr. Chair. I just want to add a few things to respond a little bit to Representative Garofalo. First of all, on the issue of MNsure, like this, MNsure, the great evil thing. The reason MNsure is in this bill is, and I was part of the work group that negotiated with the Senate over a long period of time, that was the desire of the Senate Republicans. I want you to understand that. MNsure has been doing so well and is running things so smoothly that they wanted MNsure to do this. Now, what MNsure is being asked to do here, as Representative Howard said, is pretty limited. But that was not coming from us. That came from them. I just want you to understand that. The issue about attesting, as Representative Howard said, you have to remember that this is a drug that if you don't get it when you need it, you become very ill very quickly, you rack up tremendous costs, and you can die. And we've seen that this has happened. So everything is a balance. When you set up a program, it's a balance between how much program integrity are we going to do, if you will, versus how long does that take and what hoops do people have to jump through. And so there's been a lot of consideration of how can we strike the best balance here. And, no new program is perfect out of the box. I would be shocked if this didn't have to be in some way adjusted going forward in future years. But the idea of attesting is because, and this part, I have to tell you, the Senate Republicans also agreed on, that attesting is the way to go because otherwise the process is too long. When somebody like Alex Smith shows up at the pharmacy and doesn't have the money to get his insulin, it is a true emergency. And so we would rather err on the side of somebody getting something that maybe they shouldn't really be entitled to, because the thing we risk if we don't give it to them is that they will literally die. So that is the calculation that's being made here, notwithstanding, I hear your concerns. I don't know, maybe putting in a word that it has to be I don't know, we could maybe think about, I don't know if Representative Howard would be willing, but the issue about Minnesota residency, I don't know, maybe that could be handled simply. But anyway, the final thing I wanted to say is, I love how some of the Republican members are just loving on the Benson provision that is being credited with bringing down the out-of-pockets on insulin. Well, we have an answer for you. If you love that, and if it really worked, we've got a bill to do that for all the drugs. So it should work beautifully for all of them if it worked for the insulin. And so you probably will be seeing that this year. And it's great, you know, I mean, if that was really the cause, and I have to tell you, that's greatly disputed by a number of different people, whether Senator Benson's provision was responsible for that. But if it was, then let's do it for other drugs too, because patients are sure having a hard time paying for their pharmaceuticals, even when they have insurance.
You were the one that was concerned about midnight. Yeah. Right ahead.
Well, thank you, Mr. Chairman, and thank you, my colleague, Representative Liebling. I do think it's important to point out that what's happened in Minnesota with the Minnesota regulated plans, the $0 copays, the $25 copays, that ain't happening in any other state. Even in Colorado, where they put a cap, a hard cap on insulin copays. And so what has happened is Representative Benson, and I understand some DFLers are upset about this, but Representative Benson kind of tricked the DFL into making her point. The point was that the insulin manufacturers were not the ones getting the money. The money was going to the health plans. They were making money off of insulin and using it to lower premiums and pay for other costs. And to me, it seems, and again, I understand that's not the narrative. That's not what people want to point fingers at the insulin manufacturers, but the results were pretty stunning. I mean, it's pretty incredible what's happened in Minnesota in the last 6 months with that one change. And with regards to your other issue regarding having that apply to all medicines, I would be 100% in favor of that.
Good.
Why would we take the rebates the medicine producers are giving? Why would we want that money to go anywhere else than to the consumers who are purchasing the medicine? It defies logic. It doesn't make any sense. But what I quibble with and what I dispute is that somehow Senator Benson's provision was just an unrelated factor. No, that's not what happened. It was one of the 10 smartest things I've seen in my 16 years in the legislature, and Senator Benson, instead of being demonized, should be credited for bringing low-cost insulin to thousands of Minnesotans. Even testifiers who Representative Howard has invited before committees have put stacks of money on the table talking about how much it's cost and then said, well, but yeah, we get our insulin cheap now because of the MNsure plan. So I don't think she's getting the credit she deserves for it, and it is a huge change. That's it. I'm done.
Any further discussion? Representative Evelyn, would you care to renew your motion?
Yes, Mr. Chair, I will renew my motion and just would say that nobody is, you know, if indeed this is something that is because of something that she did, great. It's great. Let's do it for all the drugs and, you know, and I'm glad we'll have your vote on that. So with that, I renew my motion that House File 3100 be re-referred to as amended, and the third engrossment be recommended to be placed on the general register.
Okay, the motion is before us. Any further discussion? Seeing none, then all those in favor signify by saying aye.
Aye.
Opposed, motion carried. No. And
Thank you, Mr. Chair.
Mr. Howard?
Thank you, members of the committee.